This is an overview of the anatomy of the respiratory system using the images out of the McKinley textbook. In this image, we see the division of the respiratory system in both a structural and a functional organization. Structurally, the tract is divided into an upper respiratory tract, head and neck, and lower respiratory tract, trachea, bronchi, and lungs. Functionally, the tract is divided into the conducting zone. Air is moved by pulmonary ventilation, and a respiratory zone. Diffusion of oxygen and carbon dioxide drives gas exchange. The respiratory tract is lined with a mucous membrane. The epithelium of the upper respiratory tract, except the oropharynx and laryngopharynx, and most of the larger structures of the lower respiratory tract, is a pseudostratified ciliated columnar epithelium with abundant goblet cells. All mucous membranes have a thin lamina propria connecting to the epithelium via the basement membrane. The lamina propria is areolar connective tissue containing the blood supply for the epithelial cells. As air moves from the larger to the smaller bronchi, the epithelium transitions to simple ciliated columnar epithelium, then simple ciliated cuboidal epithelium, then loses the cilia in the terminal and respiratory bronchioles. In the respiratory zone, alveolar ducts and alveoli are composed of simple squamous epithelium. In the regions of the pharynx and larynx where food or liquid might come in contact with the lining, stratified squamous epithelium is found. Here we see the structures of the upper respiratory tract, including the nasal cavity and regions of the pharynx. The pharynx is subdivided into the nasopharynx, the oropharynx, and the laryngopharynx. Only the nasopharynx is dedicated to the respiratory system. Recall that it contains the adenoids or pharyngeal tonsil and drains the auditory or eustachian tubes from the middle ear. As you've already learned, the oropharynx and laryngopharynx are common pathways for both air and food or liquid. The external structure of the nose includes the nostrils or external nares. Most of the external nose is composed of cartilage. The lateral wall of the nasal cavity is seen here. The olfactory epithelium is limited to the upper region, above the superior nasal concha. The meatus that lies under each concha is more clearly seen in a frontal section. The conchae are folds that increase the surface area covered by the respiratory epithelium, which filters, warms, and humidifies inspired air. The floor of the nasal cavity is formed by the hard palate and the anterior portion of the soft palate. The posterior region of the soft palate forms a division between the nasopharynx and the oral cavity. When you swallow, it is elevated and pressed against the posterior wall of the pharynx to prevent reflux of liquids into the nasopharynx and nasal cavity. The maxillary sinuses, one of 4 types of paranasal sinuses, are hollow compartments within the maxillae. These air-filled spaces lighten the weight of the facial bones and provide resonance chambers for speech. In addition to the maxillary sinuses, there are also sinuses in each side of the frontal bone, one in the sphenoid bone inferior to the sella turcica, and numerous small air cells within the ethmoid bone. All paranasal sinuses connect through small passageways to the nasal cavity. Their cilia beat toward these openings, keeping the sinuses clear of particulate matter or microbes. Inflammation, sinusitis, or blockage can contribute to infection, as the accumulation of fluid and mucus can allow the growth of bacteria. In this image, you can see the pathway for the auditory tube. Adjacent to the pharyngeal tonsil and a small tubal tonsil. Tonsillitis can block the drainage of the auditory tube, contributing to otitis media, inflammation of the middle ear. Note that the laryngopharynx leads posteriorly to the esophagus and anteriorly to the larynx. The larynx can be identified by its large thyroid cartilage, inferior to and suspended from the hyoid bone. In these views of the larynx and hyoid bone, note that the membranes are named for what they connect. The thyrohyoid membrane connects the thyroid cartilage to the hyoid bone. Note that the cricoid cartilage's largest region is only visible in the posterior view. Anteriorly, it forms a slender ring that connects the thyroid cartilage to the trachea. Both of these principal cartilages are attachment points for muscles. In the posterior view, you get a clearer image of the shape of the epiglottis. This leaf-like structure, made of elastic cartilage, will fold down when you swallow to prevent the entry of food or liquid into the larynx. When it fails to close properly, such as when someone has a stroke, the entry of liquid or food can trigger strong coughing fits. In these images, you can see the architecture of the vocal cords. The vocal folds are anatomically the vocal cords, as they produce sound when they vibrate. The parallel vestibular folds are sometimes called false vocal cords, since they do not vibrate and produce sound. The small cartilages of the larynx control the stretching of the vocal cords and also move them together to produce sound. In this image, you can see that the trachea is composed of incomplete cartilage rings. We often describe them as C-shaped, as they are open in the back. A slender, smooth muscle layer, the trachealis muscle, connects the two sides of each C-shaped tracheal cartilage, permitting a slight constriction, which increases airway resistance, or, when relaxed, allowing a slight distension of the neighboring esophagus into the space occupied by the trachea. At the carina, the endpoint of the trachea, the two primary bronchi diverge to provide airflow to each lung. The trachea is lined with a mucous membrane, rich with goblet cells, scattered among the ciliated, pseudostratified epithelial cells. Deep to the lamina propria, the submucosa contains tracheal glands, whose secretion help moisten the tracheal surface and float the mucus secreted by the goblet cells. This serous secretion is thin, increasing the ease of the tracheal cilia in beating the mucus up and out through the throat. Here you can see the organization of the bronchial tree. Far from random, the branchings from each primary or main bronchus to secondary are set. One secondary or lobar bronchus to each lobe, meaning 3 on the right and 2 on the left. Off each secondary, specific tertiary or segmental bronchi subdivide the lungs into specific bronchopulmonary segments. Within each segment, smaller bronchi branch, eventually giving rise to bronchioles. All bronchi contain rings or plates of hyaline cartilage within their walls, preventing complete closure from the also present circularly arranged smooth muscle. Contraction of this smooth muscle, bronchoconstriction, can increase airway resistance, and bronchodilation will reduce resistance. Here you can see the transition from trachea to bronchial tree. Note that the main bronchi have cartilage rings, and smaller bronchi have cartilage plates. At the level of the bronchiole, cartilage is not found, and bronchoconstriction, along with mucus buildup or inflammation, can completely close off these smaller airways. The terminal bronchiole is the end of the conducting zone, and the respiratory bronchiole is the beginning of the respiratory zone, where gas exchange can occur between air and blood in the pulmonary capillaries. The greatest surface area within the respiratory zone is found in the alveoli. In this image, you can see the combined branchings of the pulmonary artery and the bronchiole, which parallel each other at this smallest level within the lung. Follow the pathway of blood from the branch of the pulmonary artery, carrying deoxygenated blood to the pulmonary capillaries that surround each individual alveolus. From there, blood flows to the branch of the pulmonary vein. These branches eventually combine to rejoin the larger branches of the airway and artery so that you can see a bronchus, artery, and vein side by side. Note the small bands of elastic fibers surrounding each alveolus. Elastic recoil is one of the forces that balance to allow easy inspiration and expiration while preventing collapse of the lungs. Also note the numerous alveolar pores that interconnect the alveoli. In the micrographs, you can easily distinguish an alveolar duct as the main passageway through an alveolar sac. Finally, notice the layer of connective tissue around the entire region. This will have quite a few elastic fibers, along with an excellent lymphatic drainage to prevent fluid from building up around the alveoli. That would be pulmonary edema, which can cause the lung to collapse. Once again, you can see that the alveolar pores allow the free movement of gas molecules between alveoli. Remember that here the distances are small and diffusion gradients are driving the movement of oxygen and carbon dioxide. The alveolar wall is composed mostly of pulmonary or alveolar type 1 cells. These epithelial cells are classified by shape as simple squamous epithelium. There are 2 other cell types in the alveolar wall. The type 2 cells are also called septal cells. These cells secrete surfactant, a chemical that lowers the surface tension of the alveolar fluid, thereby reducing the risk that the lung will collapse. Premature newborns often don't secrete sufficient surfactant and must be put on ventilators until their lungs can mature. The third type of cell is the alveolar macrophage. Notice that it can actually move into the airspace, crawling over the surface to remove any inhaled particles that are small enough to avoid being trapped higher up in the respiratory tract. If macrophages eat too much, they can actually crawl right up into the bronchiole to be expelled with the mucus that lines the tract. Now let's turn our attention to the respiratory membrane. Here we see a tight connection between the simple squamous epithelium of the alveolus and the simple squamous epithelium of the pulmonary capillary. Note the lack of areolar tissue between the two cells. They share a basement membrane. The distance across the respiratory membrane is only about 1/2 to 1 micrometer. This very short distance is the pathway for oxygen and carbon dioxide to diffuse in the process called gas exchange or external respiration. On the air side, oxygen must first dissolve in the alveolar fluid that coats the alveolar epithelium. Now we turn our attention to the lungs within the thoracic cavity. The diaphragm is a bell-shaped muscle with a central tendon at its superior aspect. It forms the floor of the thoracic cavity and contracts to elongate the cavity. The ribs and their associated muscles, the intercostal muscles, form the walls of the thoracic cavity. When the external intercostal muscles contract, the ribs are pulled outward, expanding the volume of the thoracic cavity. Contraction of the internal intercostal muscles has the opposite effect, pulling the ribs downward and compressing the contents of the thoracic cavity. The names of the surfaces of the lungs are self-explanatory. Here you can see the right and left lungs. The right lung has 3 lobes, superior, middle, and inferior, separated by a horizontal fissure and an oblique fissure. The left lung has 2 lobes, superior and inferior, separated by an oblique fissure. The apex of each lung is its superiormost region. The base of each lung forms the diaphragmatic surface. The hilum of each lung, on its mediastinal surface, is the point of entry and exit of the primary bronchus, along with the already branching pulmonary artery and pulmonary vein. Here you can see the anatomically distinct segments of each lung. Each segment receives its own tertiary or segmental bronchus. An infection of a lung can potentially be confined to a specific segment, since each segment is partitioned off from neighboring segments by a connective tissue septum. Here is an overview of perfusion, the blood supply of the lungs. Recall that the pulmonary arterial system carries deoxygenated blood, and the pulmonary venous drainage carries oxygenated blood. The pleural cavity is a potential space between the parietal pleura and the visceral pleura. This space is really nothing more than a thin film of serous fluid, the pleural fluid, that reduces friction and drag as the membranes glide during expansion and recoil of the lungs. The pressure difference between the intrapulmonary pressure and the intrapleural pressure is necessary to keep the lungs inflated. If the intrapleural pressure ever exceeds the intrapulmonary pressure, atelectasis, or lung collapse, will occur. This concludes our review of the respiratory system.